Welcome to this explainer. Today we're going to completely demystify hypertrophic pyloric stenosis, basically breaking down how modern medicine turns a terrifying pediatric emergency into a totally manageable condition. Let's jump right in.
Here's our roadmap for today. We'll start with understanding pyloric stenosis, then move into signs, symptoms, and diagnosis. Third, medical management and resuscitation. Fourth, surgical treatment options. And finally, nursing care and recovery.
To kick things off, I want to share this quote from Willis J. Potts back in 1960. He said, "The operation for pyloric stenosis is the most satisfactory procedure in the entire field of pediatric surgery." This really hits the nail on the head regarding why this condition is so profound. You've got this agonizing situation where a sick baby is vomiting up literally all its feedings, the parents are completely distraught, and then a simple operation is performed, the baby instantly thrives, and the relief is just incredible.
All right, Section 1, Understanding Pyloric Stenosis. Let's establish the baseline here and see what's actually happening inside the infant's body.
So what exactly is HPS? Well, it's one of the most common GI disorders in early infancy. Basically, the circular muscle of the pylorus, which, if you remember, is that little valve at the lower end of the stomach, it thickens and hypertrophies. It swells up so much that it practically chokes off the passage between the stomach and the small intestine. And we've got to keep this in mind as we move forward. This near-complete anatomical obstruction is the core mechanical problem driving every single clinical symptom we're going to talk about.
Now, it's really interesting to look at who actually gets this. The exact cause is multifactorial, it's kind of like a perfect storm, but knowing the typical profile helps clinicians spot it early. It usually hits infants between 2 and 6 weeks of age, and there's a huge male predominance here. Boys are 4 to 5 times more likely to get it, and get this, about 30% of all cases are firstborn males. We also see strong associations with formula feeding, certain genetic histories, and actually postnatal exposure to macrolide antibiotics like erythromycin. Those can trigger really strong gastric contractions that contribute to the muscle hypertrophy.
And taking a look at this ultrasound, you can brilliantly see the pathophysiology hidden beneath the surface. Research tells us that things like impaired neuronal nitric oxide synthase and gastric hyperacidity disrupt the smooth muscle's ability to relax, which leads to this marked hyperplasia of the muscle layers. When looking at the imaging, what you're really hunting for is a muscle thickness of more than 3 millimeters and a channel length greater than 15 millimeters. You spot those measurements and boom, you have your diagnosis for sure.
Section 2, Signs, Symptoms, and Diagnosis. Now that we understand the internal mechanics, let's explore how this blockage violently presents itself in what was a perfectly healthy newborn. This step-by-step clinical escalation is wild, and it shows how fast a starving infant can approach hypovolemic shock. It generally starts out looking like simple regurgitation after feeds, but because the stomach outlet is totally blocked, it rapidly escalates to the classic hallmark symptom, non-bilious projectile vomiting. It's forceful. But here's the thing, the baby isn't nauseous at all. They're actually ravenous and constantly hungry right after they vomit. As this relentless cycle continues, you see severe dehydration, weight loss, and lethargy. Clinically, in up to 80% of cases, you can literally feel a firm, mobile mass in the right upper quadrant of the baby's abdomen. Clinicians always describe it as feeling exactly like an olive.
So put yourself in this scenario. You're facing an infant in critical distress, severe dehydration, and you feel that palpable olive mass. How do we pull this infant back from the brink and actually fix this?
Section 3, Medical Management and Resuscitation. Before we even think about a definitive surgical fix, we have to address the severe biochemical chaos going on inside this baby.
This is an absolutely crucial takeaway. You cannot just rush this baby into surgery. No way. Because the infant has been forcefully vomiting up pure stomach acid, they've lost massive amounts of hydrochloric acid. That results in a dangerous, highly specific state called hypokalemic metabolic alkalosis. You have to aggressively correct these profound electrolyte imbalances first. We're talking IV fluid resuscitation with isotonic crystalloid boluses, followed by adding potassium chloride to their maintenance fluids. If you skip this and administer anesthesia while they're still in severe alkalosis, the infant's respiratory drive will be suppressed, and they could go into severe postoperative apnea. So, medical stabilization, it's literally mandatory.
Okay, once they are stabilized, how do we fix the actual physical blockage? Looking at this comparison, you can clearly see why surgery is the globally recognized gold standard. You could try medical management using atropine sulfate to suppress muscle spasms, but the success rate is only around 66 to 73%, and it requires a really long hospital stay of about 10 days. We generally only use that if surgery is absolutely contraindicated.
Surgical management, on the other hand, gives you a 100% success rate. It's a definitive cure, and it usually gets the baby back home in just 3 days.
Section 4. Surgical treatment options. Let's actually head into the operating room and look at the mechanics of this incredibly effective fix.
As you can see here, there are two main surgical approaches. You've got the traditional open right upper quadrant incision, where the pylorus is actually delivered outside the body to work on. And then you have the increasingly popular laparoscopic method, offering a direct internal view through tiny incisions. But honestly, whether the surgeon goes open or lap, the underlying goal is exactly the same: perform a safe, precise, extramucosal myotomy.
The specific procedure they use is called the Ramsted's pyloromyotomy. This technique was first described over a century ago, and the beauty of it lies in its absolute, elegant simplicity. The surgeon makes a sutureless, longitudinal split right through that thickened outer pyloric muscle. The trick is to stop just before cutting into the delicate inner mucosa. By simply spreading that cut muscle apart, they literally crack open the restriction. It instantly relieves the obstruction, and normal digestion can finally begin again.
Section 5. Nursing care and recovery. Fixing the muscle is great, but it's really only one part of the journey. Comprehensive, holistic nursing care is what safely gets this infant back to their family.
Nurses carry this incredible dual burden. They have to manage the physical recovery of a tiny infant while simultaneously treating the severe emotional distress of the parents. We can break this down into 3 pillars. First, hydration and nutrition. It's amazing, but infants can actually resume carefully monitored oral feeds just hours after surgery. A little regurgitation is totally normal as the stomach wakes back up. Second is physical integrity. Babies who are temporarily NPO need pacifiers to satisfy that vital sucking reflex, and their skin needs meticulous protection from the earlier dehydration. And finally, and this is a big one, family support. Think about it. These parents have been watching their newborn literally starve. Transparently educating them about the IV fluids, the surgical fix, and setting realistic expectations for recovery is absolutely paramount for relieving their anxiety. I want to leave you with this thought. A long time ago, before modern medicine, this was often a really grim diagnosis. But today, it's one of the most satisfying cures in all of healthcare. Think about how the seamless integration of rapid ultrasound diagnostics, aggressive biochemical resuscitation, a beautifully precise surgery, and empathetic nursing care can entirely reverse this condition. It's a perfect orchestration that transforms a starving, critical infant into a thriving baby ready to go home. Thank you so much for joining me on this explainer. Keep questioning and keep learning.